So we will start this morning with Angel Boling. Dr. Boling is an assistant professor of nursing and baccalaureate program chair at Baptist Health Sciences University in Memphis, Tennessee. Her research work has been focused on interprofessional education at the undergraduate level for healthcare programs in an effort to prepare graduates to provide safe, quality patient care. Before coming to BHSU, she worked as a bedside nurse, preceptor, educator, and charge nurse for a level 1 trauma burn center for 16 years. She received her master's in nursing ed from the University of Memphis and her doctoral degree in nursing in 2020 from the University of Missouri, Kansas City. So Dr. Boling, welcome, and the floor is yours.
Good morning. Am I able to share my screen, Christina?
Yes, ma'am, you certainly should be.
All right. I'll make sure everybody can see this and I'll get a slideshow going. So good morning, everyone. My name is Dr. Angel Boling, and I would like to present some of my dissertation work. My focus with dissertation was to look at interprofessional simulation among healthcare students, which I conducted a randomized controlled trial to improve communication self-efficacy. So just some background information in regards to the statement of the problem. It's important to recognize that ineffective communication is the basis of 70% of medical errors, which commonly result in adverse and sentinel events. And this continues to be the second leading cause of medical errors in the United States, just as updated in 2021. And so multiple healthcare organizations, including the Institute of Medicine, as well as the Joint Commission, continue to recognize that this is a preventable problem and have continued to enact strategies, but these strategies have been ineffective. Traditional education strategies, the use of lecture and clinical, have been noted to be ineffective for teaching communication, and a need for innovating teaching modalities are needed to enhance communication training in healthcare programs. With this being found, my focus was on the use of high fidelity simulation as that innovation and that teaching methodology that we could utilize to teach communication skills within the healthcare educational environment. The background to the problem, of course, as I started getting into it, communication skills and training have varied among academic settings in multiple countries, with a multitude of various teaching methodologies being used to teach communication skills. And so this is not just strictly focused in on the United States. I looked at this also at a global aspect. And so this is very well known. We found out that a lot of didactic instruction can give students the fundamental principles of communication, but they do not allow the opportunity for application and the practice of these skills in the professional settings. Multiple reviews of literature found that the interactive methods of teaching are more successful, of course, in helping individuals to acquire communication skills in comparison to use of didactic methods only. One of the things that we recognized, there was a dearth of communication research when I got heavy and deep into this. And we continue to recognize that nurses and other healthcare professionals are lacking the necessary communication skills for effective communication and collaboration, which is largely due to this ineffective and inadequate method to train our students in healthcare programs. So my hypothesis, the purpose of this study was to examine healthcare students' communication self-efficacy using a high fidelity simulation intervention with an interprofessional group of students in comparison to an intraprofessional control group. It's important to recognize that, that healthcare students really struggle to really pull this piece together. It's considered a soft skill, and so we have to think about how we can bring this back into play and really focus on this in the educational setting. One thing to know is that when we talk about self-efficacy, it's been defined as a belief in one's capabilities to overcome the demands of a situation to achieve a desired outcome. And so knowing that self-efficacy and its associated perceptions have been identified as a component of behavioral prediction, we know that academic performance can be motivated by self-efficacy, and a positive relationship has been shown to exist between self-efficacy and performance mastery. Despite all of these findings within research and in education, the overall focus with self-efficacy has only been focused on behavioral change or an outcome that occurs, and not the student's own perceived self-efficacy with communication. So in order for healthcare educators to understand and recognize the impact that simulation has on student self-efficacy, as well as an adjustment in behavior and skill attainment, educators must understand first how high fidelity simulation can be used as a teaching modality with healthcare students. So the research that I conducted addressed this gap by examining the use of high fidelity simulation on student self-efficacy of interprofessional communication skills. So the hypothesis for this research was that healthcare students who participate in a high fidelity interprofessional simulation scenario will have increased communication self-efficacy than those students who participate in a high fidelity intradisciplinary simulation scenario. The two research questions that were examined was, what effect, if any, does an interprofessional high fidelity simulation have on a healthcare student's communication self-efficacy? And the second research question was, what effect, if any, does an interprofessional high fidelity simulation have on healthcare students' communication self-efficacy? Of course, we have to look at the significance of this research. The purpose of this study, of course, was to help healthcare programs meet this challenge. All healthcare programs, despite whether they're undergraduate or graduate, must meet the competencies of their accrediting bodies. They must also prepare their graduates to care for their patients and provide safe, quality care. They must also be able to teach effective communication skills to their graduate that can be translated into practice, and they must prepare graduates to work in interprofessional teams. Currently, there are a lot of challenges within the healthcare programs to teach communication skills, things such as an increased student to faculty ratio, availability of clinical sites to take our students to, a lack of appropriate learning environments, as well as the need for ongoing interprofessional education. So we have to recognize, with the increasing complexity of patient care, evidence continues to support the need for interprofessional education. While the Institute of Medicine, as well as the American Association of Colleges of Nurses, have worked together in conjunction to look at interprofessional education as a key component of healthcare education, which in turn will further encourage communication and collaboration and help translate what we're teaching in the healthcare educational environment into practice. As I stated earlier, when we got into the research, and I focused first on communication skill training, there is a lack of research. There were a lot of inconsistencies within the healthcare educational industry on how we teach communication skills. There was a paucity of research that actually was identified in just communication skill development itself. And there's no one teaching modality that exists to show that there's a difference with that behavioral change. And of course, we know there's a need for realistic environments for teaching. And so with that mindset, the use of high fidelity simulation is a perfect teaching modality. This provides realistic environments that provide students with necessary experiences to develop communication skills as well as communication self-efficacy. Simulation can provide an environment that's risk-free to patients and allows for multiple learning opportunities to help develop interprofessional communication with the use of debriefing and reflection. So even though we know that high fidelity simulation is a teaching modality that has potential to teach communication skills, there is still minimal research available that exists on the effectiveness of simulation. And so the use of healthcare simulation is a necessary environment that we can research the opportunity to use this for the training and or curriculum development to fill the gaps that are currently in our healthcare education programs. Just as a quick review, of course, the concepts that were looked at for this, the first one was, of course, communication. We know that communication takes on many forms when it's actually done. The most common, of course, is written and face-to-face. Written has been noted as the preferred method in healthcare, yet we know just working in healthcare that this lacks the uniqueness of face-to-face, which employs the use of body, language, and expression. And it also brings in the subjective view of the individual to allow for a further processing of that dialogue that happens. In healthcare, the most common forms we see are the nurse-patient. And so that's where nurse-patient communication is a very multidimensional aspect. It does involve more than just the transmission of information, but it also brings in the feelings and the relationship that one develops with the patient. Interprofessional communication, though, involves the transference of knowledge and information that takes place between disciplines of healthcare, primarily 2 or more disciplines. Then it's important to recognize and understand the different dimensions of communication and what they are. It's very simply defined as a 3-dimensional space. That first dimension is where the message is moved forward. The second dimension brings in the attitudes and the feelings that actually help affect whether the communication is positive or negative. And the third dimension is that interaction and that relationship that's built. It is important to recognize that communication, especially effective communication, is very important among healthcare teams, and it's essential to continue to provide safe, quality care. We know that ineffective communication in any healthcare setting can lead to negative outcomes for the patient, including compromised patient care, discontinuity in patient care, patient dissatisfaction, as well as the economic consequences that actually affect the healthcare institution. The other concept that was focused on was understanding what is simulation. Simulation itself, the history of it actually goes back to the medical simulation and the theater format that we see a lot in movies, or we may see in books that we read, back to that England mindset of actually doing the theater. It was also used in military and aviation. This was used as a mechanism to provide scenarios that would help the people that are involved in different types of communication and or collaboration or different scenarios, help them manage and respond and be effective with that. Medical simulation, of course, was the next big step. They brought this in because they recognized the need for a more authentic method to enhance skill obtainment, to focus on critical thinking and clinical judgment. And then, of course, simulation was not formally introduced until the late 20th century due to the need for a more modernized approach to help teach about how to care for a patient in a healthcare environment through a realistic approach. There are 3 forms of simulation. Low fidelity is focused more on task trainers, mimicking of different skills and assessments. Medium fidelity is more of an advanced focused, whereas our high fidelity simulations utilized advanced computerized technology for physiological responses that provide a more realistic presentation. High fidelity has been found to assist with higher levels of knowledge transfer and improving clinical judgment, communication skills, and critical thinking. With a quick mindset, the literature review showed that we utilize the keywords of simulation, nursing simulation, communication, interdisciplinary, and the additional search terms brought in the terms of interprofessional, self-efficacy, and communication skill. The databases that were used were PubMed, ProQuest Nursing and Allied Health, ScienceDirect, EBSCO, and of course, PsycInfo. We looked at a variety of different disciplines, nursing, medicine, as well as healthcare education, that brought in computers, academics, and of course, psychology and sociology for the theoretical component. The theory that was chosen was Bandura's self-efficacy theory. This was developed in 1977 and later enhanced in 1997. Has a very specific definition and belief in one's capabilities to overcome the demands of a situation in order to achieve a desired outcome. And we do know that this has been linked with the predictor behavior, which leads to outcome expectations. Associated attributes is a person's perceived capability that they can do something. Of course, their confidence, the perseverance to complete a task or goal, the ability to handle challenging or changing situations, and the perceived belief in setting or obtaining goals. This is the basic self-efficacy model. It identifies 4 areas known as efficacy expectations. And so this was the directional approach on the development of looking at self-efficacy judgments, which then impacts behavioral performance. We see performance accomplishments, which are the use of enactive mastery experiences and past experience, which influence how we think. Vicarious experiences, which is the use of modeling behavior, and hopefully it's a modeling of successful behavior, which can change and impact a person's judgment and impact their behavioral performance. Social persuasion is a big one, develops through coaching and mentoring as well as feedback to hopefully increase motivation and self-confidence. And then of course there's the physiological and emotional state, which actually focuses on the emotional factors such as stress, anxiety, and fear can affect it. This is actually my self-efficacy research model. The thought is the use of high fidelity simulation provides an inactive mastery experience that can be evaluated through the self-efficacy model. With this model, we'll see that a person's perceived capability and competence impacts their own self-efficacy. With the use of simulation and debriefing in red, we have the 4 self-efficacy expectations. And so the thought is that through the self-efficacy expectations, which is performance accomplishments, previous experiences noted with SIM, vicarious experiences, which is modeling through interactions with the peers and faculty, social persuasion, which is the coaching done during the debriefing process. And then of course, we have to take in the psychological emotional stress. There's to be found some performance anxiety and simulation. If this provides a positive outcome and actually helps this process of use of simulation and debriefing, can actually provide that experience that will actually impact their levels of self-efficacy. And it's an ongoing continued thing with every experience. The research methodology and study design, we utilized a quantitative study to look at this. The study design was a randomized controlled trial. So we had a interprofessional group, which is comprised of students from more than 2 healthcare disciplines, where an interprofessional group consisted of students from 1 healthcare discipline. Students, of course, were randomized and assigned a number from 1 to 4, as well as a letter per each discipline, in order to assist with random assignment to the intervention or control group. High fidelity was chosen as the teaching modality. This also included pre-briefing and post-intervention debriefing to examine communication, self-efficacy, and whether differences actually exist between the intervention group and the control group. The research instrument that was used was the Communication Skills Perception Questionnaire. We, of course, obtained baseline demographic data. Data collected included the following. We collected age, race, gender, healthcare discipline program, prior healthcare experience, and number of prior experiences with simulation. We also decided to add some demographic data to determine if a student had been in the healthcare discipline before with that prior healthcare experience, because we knew that may potentially have an impact on how they communicate with healthcare teams. This was a 33-question item survey instrument. It had 6 different items related to communication skills with patients, healthcare members, addressed roles and responsibility of the teams, of course, hierarchy in healthcare teams, as well as communication self-efficacy. It was a 5-point Likert scale. Students were actually did this pre-simulation and then did this again post-simulation. This was actually done, so this initially is a pilot test and was done by original authors and revisions made at a Eastern Tennessee University, utilizing pharmacy students, physical therapy students, and medicine students. So this was the first time this research instrument was used with undergraduate students. No other psychometric testing was conducted to assess the validity and or reliability of the developed questionnaire since it was done before this study. The procedure, we had institutional review board approval from the research site as well as the University of Missouri, Kansas City. All the prospective participants were identified after consultation with the chairs of each undergraduate program. Each student was invited to participate in the study via email. This email is very simple, included the purpose of the study, inclusion, exclusion criteria, and the primary investigator contact information. Students were then screened to see if they met this criteria. And then once they were agreed to participate, they were then randomized to either the intervention or control group. Informed consent, including risk and benefits, was explained to all participants. To maintain fidelity and integrity of this intervention, an intervention protocol was developed that included the study purpose, goals, objectives, and steps of the intervention to be carried out. A simulation educator was trained by the primary investigator to do the intervention protocol and conduct all simulation experience. The simulation educator and primary investigator were there at all times, but the primary investigator did not participate in the simulation aspect itself. We did the research questionnaire as a pre-post survey. Very quick, so I don't want to run out of time. Of course, data collection, all data was de-identified. Paper surveys were stored and locked up. Data storage was kept. All data was saved on a password protected computer in a locked office. Data analysis, we used SPSS for actual statistical analysis. We used descriptive stats to look at demographic data and paired t-test to compare intervention versus control group, looking at pre and post intervention to examine the variables of communication and self-efficacy. The sample, of course, was done at the Baccalaureate Health Science College, which we're now a university. The inclusion criteria is that students must be seniors in their healthcare program and have participated in at least one simulation experience to decrease the anxiety and performance stress. The convenient sampling, we had 36 students that met inclusion criteria with 22 students participating. A power analysis was conducted for this study that determined we need the sample size of 40. Based on these aspects and the size of the actual sample, we decided that this study was deemed as a pilot. There were a lot of variables in sample size, attrition and respiratory in the allied health programs. There was a lot of conflicts with scheduling with the actual research study intervention, which made it difficult for us to get a much larger sample. Okay. As I talked about earlier, these are the descriptive statistics, ethnicity, age, gender, healthcare program, simulation experiences, and previous healthcare. So what was found? Descriptive statistics of the ethnicity. We know the majority of the study population was Caucasian, with African American coming in as second, with no Asian populations. The majority of the control group was Caucasian, with African American coming in second. The majority of the intervention group was Caucasian, with African American coming in second. The sample population itself is not representative of the institution's reported student diversification. And so with that, we know the sample population of the study actually overrepresents the Caucasian population, while underrepresenting the African American population that was actually there at the university. For the age of the study population, the majority of the study population were between the ages of 19 to 25, with all other age ranges consisting of 1 to 2 participants, primarily in the control group. No participants were noted in the all age groups above 31 for the intervention group. Gender, the majority of the study population were a female gender, with males as the minority group. Additionally, female gender was noted in both the control groups and intervention groups as the majority study population. For the healthcare programs, the majority of the study population was, of course, nursing, with the second largest group being identified as allied health. Nursing was a predominant group noted in control and intervention groups. Number of respiratory students and allied health students were decreased due to the availability as well as program attrition. For the simulation experiences, the majority of the study population that they indicated that they had had more than 5 or more simulation experiences. So that was very helpful to know that students had already spent time in simulation and were familiar with that, and hopefully that decreased the performance anxiety. For those that had previous healthcare experience, the majority actually did not have any. We had 6 that did, and so we did not feel like that this impacted our actual study. For our tested hypothesis, we use an inferential statistics. We use paired t-test versus Wilcoxon's test. We felt like this was the best thing to look at pre and post data. This is our control group. We'll notice with the control groups, this 13 participants had an average difference from pre to post, with no statistical difference noted in communication. This is the paired t-test for the control group with communication self-efficacy scores. There was no statistical difference in the control group. And then we have all the different paired t-tests that if you wanted to spend time, you could notice, but there's no actual changes between pre and post. But where we did notice our changes is that the paired t-test for the intervention group showed a statistically significant change with patient communication and confidence with interprofessional communication. So these findings further support the hypothesis that the use of a high fidelity simulation intervention with an interprofessional group of healthcare student leads to increased communication self-efficacy. So just a very quick conclusion, and then I'll be done. The convenient sample, of course, we know is small, so it deemed it a pilot study. The convenient sample did hold at least senior healthcare students that had more than one simulation experience. Initial results indicate a statistically significant increase in the total survey score of the communication self-efficacy questionnaire for the intervention group. Therefore, we know the hypothesis would lead to increased communication self-efficacy was accepted. But we do know that also that analysis of subscales, which the different levels were broken down, we see that the interprofessional group of healthcare students not only leads to an increase in communication self-efficacy, but also an increase in student confidence when it's engaging in patient and interprofessional communication. And here are all my lovely references, the shortened version. Any questions?
Wow, that was a wonderful study.
And you and I know that was the short version of it to present.
I do. I guess it doesn't surprise me. A question I have for you as someone that has spent many years playing in all this data and the literature. What if you've got a school that truly only has one health profession? Do you have any suggestions for that program on how they can better prepare their students with high fidelity sim if they don't have any other professions to add in?
Yeah, one of the things, we've actually approached this from an undergraduate perspective, Christina, as part of our QEP. And we really hit it hard and heavy with some of our gen ed courses, where some of our gen ed courses were working together, such as like patho and universal healthcare. Those are 2 of our big courses, and how they could start working as a group, as a team, to recognize how to communicate and collaborate. So we did some of that from a gen ed perspective, because you and I know, and the majority of people on here know, that interprofessional education happens heavy at a graduate program, but when you're trying to do that undergraduate focus, it is so hard. One of the things that we did do within our region in Memphis, Tennessee, is we reached out to other schools. Like we have the optometry school down the street that has a lot of community access. So we thought about where there were different clinical experiences that other programs may be going to, and we kind of formed a collaborative to start working together. And we were doing some phenomenal work until COVID hit us. But we started to think about, who's in the same environment at the same time, and how could we start to really make a difference. One thing we did that I actually found to be very unique is we were having nursing students and respiratory students in the same intensive care unit. The faculty, we both knew each other very well, but we were like, how could we really pull them together? And instead of having them develop separate plans of care, they started developing one plan of care together. So what were, two big things that as nurses and respiratory professionals, what would they be doing, and what are some unique things that they're doing differently? And honestly, we did a lot of qualitative feedback, and the interesting part I had was not just the students working together, they also changed the dynamic of how they interacted with faculty. The respiratory students became comfortable with me as a nursing faculty and would start interacting and asking me questions about things, and vice versa. And so I think we changed that dynamic. The one thing that I will say, going to a lot of different IPE things, is when we started working with allied health and diagnostic programs, that's hard. And so one of the things we've learned how to do is how to do an unfolding case study. So some of it may be group work in a Zoom, and then some of it may be in a simulation. Some of it may come back, to a Zoom, so that we're keeping them connected. We just know, like, nuclear medicine is not going to be in a simulation for a very long period of time, but nursing and respiratory and medicine and pharmacy are going to be there. So we looked at how we could take a case study and unfold it with different types of way to do it. So that's been, I think, very helpful. My simulation educator that did this study really said that we should have done qualitative, because I didn't get to watch it because I stepped back, and he said it was interesting. Nursing got pretty far. It was a critical event, of course, simulation, and then they recognized they needed their team members. Respiratory got pretty far. Allied health struggled because they were more diagnostics, but the interprofessional team got all the way through the simulation. And so he's like, just from watching it from a qualitative standpoint of seeing how students interact and knew that they needed team members was really fascinating as well. So, but yeah, I think getting out in the community, Christina, was the way that we really approached it, to really try to start making connections. Who's in a clinical setting or community setting or wherever together that we can change the dynamic.
Right. And I know from a interprofessional leadership conference I attended last week with one of your peers, Cheryl Scott, that
yes, she and I worked very close together. Yes.
Yes, we were at the same table the last day. So I know you've got great support there. And as much as I could talk to you all day about this, because simulation is one of my favorite things in the world, we're out of time.
Yeah.
And we will move on, but thank you so much. I enjoyed your presentation greatly.
Well, the exciting part was getting through all your dissertation, and then it happened the 2 weeks after COVID. And the fact you proved your hypothesis when you were just hoping the whole time, you're like, I know this is going to do this. So.
Right. Absolutely.